Greetings, everyone. Let me present you my PhD topic about prognostic factors of serum biomarkers in urothelial cancers. My vision is therapy optimization of the urothelial cancer, and as a mission I would like to assess the utilization of different biomarkers in urothelial cancers treated with immune checkpoint inhibitors. These are my 3 ongoing projects where I will assess different biomarkers in the aspect of urothelial cancers and immune checkpoint inhibitors. So let me go one by one. My first article title is Pretreatment Soluble PD-L1 pretreatment soluble PD-L1 as a predictor of overall survival for immune checkpoint inhibitor therapy. This is a published article to Cancer Immunology Immunotherapy. So about the background, I can say that immune checkpoint inhibitors revolutionized anti-cancer therapy. We are talking about a really hot topic. As you can see, their discovery resulted a Nobel Prize several years ago. So how these drugs works? Here you can see a tumorous cells and you can see a T cells. They both expressing PD-1 and PD-L1. So if these two binds together, that causes an immune suppression, so the cancer cell will win. But what if we block it with an agent, anti-PD-L1, anti-PD-1, that causes an immune boost, so the T cell will win. So this theoretically sounds really good, but what we can see is that only 1/3 of the patients will respond to this therapy. So what we can do to increase this 30% objective response rate is to find biomarkers that to help to find the perfect candidates for this kind of therapy. So therefore, we choose the soluble, the blood version of PD-1, PD-L1. So what is the clinical question? That these biomarkers, soluble PD-1, soluble PD-L1, have a clear, well-defined prognostic value in human malignancies treated with immune checkpoint inhibitors. And if we construct a PICO framework that will look like this, we have an population of all kinds of cancer who receive this therapy. We compare the high and the low concentrations of these biomarkers, and we have an outcome of overall survival and progression-free survival. I don't want to go into the details, but after the selection process, we end up with 16 eligible articles. So about the results. Here you can see the first outcome, overall survival, with the biomarker is soluble PD-L1. And in this forest plot, we made the subgrouping based on the type of cancers. And what you can see that the heterogeneity is quite high, which I will explain you later why is that. So what are the numbers tell us? We calculated hazard ratios. If the hazard ratio is higher than 1, like in non-small cell lung cancer group, that means that high biomarker is the high concentration of soluble PD-L1 is a risk factor, meaning that these patients have worst survival rates. So that is a risk factor. So what happens when the hazard ratio is less than 1, like in esophageal squamous cell carcinoma? That means that high biomarker level is a protective factor, meaning that these patients have better survival rates. Here, the overall hazard ratio is 1.67, meaning that patients who have high biomarker level, 67% more likely to have worst survival rates. Here, the second outcome is progression-free survival with the same subgrouping, with the same heterogeneity problem. But what happened that the overall hazard ratio is lowered because we have more articles on the protective side. Here, this is again a secondary outcome. Here we assess the dynamic changes of soluble PD-L1 concentrations during several cycles of immune checkpoint inhibitor. And what's really interesting here is that I don't know if you can see it, but only the anti-PD-L1 therapy caused a really strong elevation of this biomarker. So what are the strengths of this study? That this is the first in the field, and we have significant number of articles. However, the limitations, what I mentioned the heterogeneity, it comes from we are assessing comparing different kind of cancers. These cancers are in different stages, and the cohort sizes are quite different. We have half retrospective, half prospective studies. The cutoff values where they draw the line between the high and the low concentrations were different, and they used different ELISA kits, but we did a subgroup analysis for that. problem as well. So the conclusion is that soluble PD-L1 could be a useful pretreatment prognostic biomarker. However, the prognostic value of soluble PD-L1 seems to be different around various cancers, so therefore we should interpret in a tumor-specific context, and this indicates that soluble PD-L1 might have a cancer-specific prognostic value. Implication for practice to use these biomarkers, because we can clearly still see that it's good for therapy optimization, and the implication for research is that these on-treatment flare-ups, the elevation of soluble PD-L1 seems to be therapy-specific, and its biological and clinical relevance needs to be further evaluated. My second article, name is High Pretreatment Soluble PD-L1 is associated with muscle invasion and shorter survival in upper tract urothelial carcinoma. This is also a published paper to Biomedicines. So what can I tell you about the background is that upper tract urothelial carcinoma is a rare disease. It only takes 5 to 10% of all urothelial cancers. And I would say that the main concept, there are two main concepts behind these articles, and these are different. One is that preoperative biopsy has only a limited value determining the tumor, the exact stage of the tumor. And this is a prognostic type of question. The second one, in much advanced cases, when the tumor is already metastatized and we have to give some kind of systemic agent, it could be chemotherapy or immune checkpoint inhibitor, and to find to which one should we give, it is a rather therapy predictive question. So the aim of this study to determine the prognostic and or the predictive role of soluble PD-L1, the same biomarker that what you saw in the meta in upper tract urothelial carcinoma. But this is not a meta, this is a cohort. We have 65 patients, and we have three kind of groups. We have a surgery group, a chemotherapy, and an immune checkpoint inhibitor group, and we analyzed with the biomarker with sandwich ELISA. So about the results, here you can see the association of the preoperative serum PD-L1 concentration and the clinical pathological parameters in the surgery group. And what you can see here, that there's a clear difference if you compare the lower pathological grade versus the higher pathological grade, but there is a overlap between them. But in the non-muscle invasive versus the muscle invasive stages, there are clearly difference, and in the non-metastatic versus metastatic, there's also a clear significant differences. So here, what you can see that could be really familiar with the meta-analysis, that we are assessed that how the soluble PD-L1 change during therapy. And what you can see in the surgery group, there's a significant but mild elevation of soluble PD-L1. In the chemotherapy group, there is absolutely no significant differences. And in the immune checkpoint inhibitors, which is also PD-L1, there's a huge 25-fold increase. So what we did the survival analysis in the surgery and in the chemotherapy group, and there you can see there is a clear significant worst survival rates for high soluble PD-L1 patients. About the strengths, the cohort size, I know it sounds short, 65 patients, but this is a really rare disease, and the prospective design of the is also on the strengths side, and we have different treatment setting, and this is the first article. However, the limitations that we did not make a correlation analysis of the tissue level and serum PD-L1 levels. And the cohort size in the IC and the immune checkpoint inhibitor group is so small that we could not make survival analysis. Therefore, we didn't have answer for the therapy predictive question. So this is the conclusion that because we find significantly increased soluble PD-L1 levels in higher pathological stages and association with shorter survival, therefore we think that soluble PD-L1 could be a useful preoperative prognostic biomarker. However, so the implication for practice is to, again, to use these biomarkers in therapy optimization and risk stratification models, and implication for research. Again, these on-treatment flare-ups needs to be further evaluated. And just a quick, just a few words about my third ongoing project, where I will start soon, is that about investigating the prognostic significance of neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, CRP and LDH in urothelial cancers treated with immune checkpoint inhibitors. So these are laboratory parameters which I would like to assess in urothelial cancers. I know I'm lack of time, so I will be just quick. This will be a really familiar meta-analysis which you saw in the first one, but I will assess different biomarkers. And these are my 3 ongoing projects, and I would like to thank you for your kind attention with the words of Walter that I disapprove of what you say, but I will defend to the deaf your right to say it. Thank you very much.
Do you have any clue, by the way, on this? Are there data which would explain, I mean, this kind of variability between different cancers?
So you are questioning that why is that happening?
Why is it protective?
That, for example, if I go back just a quick, that for example in renal cell carcinoma, like, or in esophageal squamous cell carcinoma, we can see that it's more like protective. In the other kind of cancers in the other side, well, it's a great question. We are talking about the soluble PD-L1, but what we can see in the PD-L1 level, which is on the cancer surface, we use that for therapy predictive role. And what we can see that, for example, also in non-small cell lung cancer and in urothelial cancer, we can say that if the PD-L1 is higher than a cutoff level, we can give immune checkpoint inhibitor because in that case it will work. But in renal cell cancer, and I think in head and neck squamous cell carcinoma, you don't use that tissue PD-L1 level because it doesn't have any therapy predictive role. And we don't know why is that happening. Basic scientists try to evaluate it. And what we can see in the soluble levels is that not with the same type of cancers, but we can clearly see that there is also tumor-specific differences.
Yeah, but also this could be a kind of interaction between the body and the cancer. I mean, the stromal cells around the cancer and the cancer cells. So this may actually
multifactorial as well.
But maybe,
yes.
I mean, this interaction that you actually, what you measure is not always the cancer, but also the reaction of the cells around. So maybe this could be one explanation why serum and
yes.
tissue level could be different.
Yes, and not just the cancer cells expressing PD-L1. So there's multifactorial.
Just now I realized that how specific the serum PD-L1 is, and in case of, for example, the surgery, you can see that it went up a bit. So when did you take the samples? How many days after surgery? Because, you know, after you cut somebody, then inflammatory and the wound healing, the part of wound healing
yes,
is activating the immune system. So how can you exclude all these
we also
we
also hypothesized that because this is a post-surgery inflammation, and not just serum PD-L1, but CRP and all kind of parameters that reflects on the inflammatory status of the human body can also increase. So we put that on the discussion part that we think that because of the post-surgery inflammation. Unfortunately, I don't know if we have samples for that, but it would be also interesting to see that how in time it would change. Like in 1 week, it stays up, but after 1 month or 2 months, it will go back the baseline level.
Yeah, and you should find a marker in the literature which is specific to inflammation, but not specific to cancer, and then
yes.
check.
First of all, for everybody, this is a good, Ádam's projects are a good example that there were previous publications in the topic, or there was a recent meta-analysis in his topic, although he managed to publish it in D1 journals. So we realized in the past couple of months that some of you got frightened because you saw a similar publications. We don't care. Go on with your project, and you see that actually after 15 months you can have your PhD. Because Ádám has his PhD finished, first of all. Second, Ádám, you were showing on your plots that in one cancer type, it may happen that PD-L1 is not prognostic or is protective. I would reconsider that part. I would say that, for example, in non-small cell lung cancer, we see a clear picture that all of the studies show the same stuff. But of course, to be able to have a conclusion, what you were
yes,
saying,
it's
that
only
it may be protective, it's one article.
Yes.
You have to see the quality of that article, and don't forget that it may happen that some of you had prognostic studies, but also in this case, we should assess the quality of evidence. So nowadays, it is not enough to have a result, but also you have to see the quality of evidence. And my question, sorry, quickly to close this presentation, that I was just wondering, what would you do if, for example, in small, okay, you're not a pulmonologist, but in any kind of cancer, then you see that there is a high PDL, serum PDL1 level before the start of the immune checkpoint inhibitor. Can you say that, okay, I won't start it because anyway?
No, clearly not.
How can this change the practice?
If we make prospective randomized clinical trials based on, for example, if we make a high soluble PDL1 level and a low PDL1 level, and in the high and in the low, we will randomize patients. And if we would say that if we, to give immune checkpoint inhibitor and, for example, chemotherapy, and if we would say that in the high group, the immune checkpoint inhibitors have significantly better survival rates compared within the high group with the chemotherapy, and in the low group we see no difference, then therefore we would say that, okay, this is a clear evidence that we have, that this soluble PDL1 is therapy predictive. But based on this, we cannot conclude that. But again, because of the data that we have.